Salam alaikum. Good afternoon. Today I'm pleased to present you Dr. Abdullah AlBahlal. I have had the pleasure to work with him during the residency for 4 years, and also he took the surgical fellowship career pathway, and also I was honored to work with him also. And now he's a consultant in the surgical division at KKH. I know that Dr. Bahlal doesn't like to be praised at all, but I tell you that very shortly that he's one of the most brightest minds I have ever had the chance to work on. So now the floor is yours for this interesting lecture.
Assalamu alaikum wa rahmatullah. Thanks for the introduction, Dr. Robio, and you are actually distinguished for me being a cataract teacher and retina teacher, and this is only special to you. So, Bismillah ar-Rahman ar-Rahim, alhamdulillah wa salatu salam ala Rasulullah. We will be presenting an interesting topic actually, and it became more interesting recently because of recent events happening in the ophthalmic society in the kingdom. In September 2021, we started receiving a shower of cases from Jeddah Eye Hospital with an outbreak of endophthalmitis occurring a few days and weeks after cataract surgery. And the shower is actually still coming, and we are receiving several cases with several pictures of clinical presentation. So we wanted, by doing this lecture, to ignite a discussion and see what's the approach of everybody from different specialties. We want to see retina approach, and as well as other specialties, what are they offering to these patients, and maybe we can try to standardize and uniform the approach to these patients. As I noted that the treatment and management can be variable across clinicians and surgeons in different specialties. So you'll find a retina surgeon who's doing core vitrectomy as a first surgery, and some other people will do aggressive complete vitrectomy with IOL removal and injection of all available antifungal agents for these patients. So we'd like to see what would the presentation provide to us, and what would the attendee provide by discussing at the end. So we'll be speaking about the etiologies of fungal endophthalmitis, specifically exogenous fungal endophthalmitis, and the possible clinical presentation scenarios and diagnosis. What are the methods of diagnosis of such disease, and what are the possible management and complications? So endophthalmitis has been defined as a bacterial or fungal infection of the internal ocular structures with involvement of the vitreous. So this definition seems to be agreed upon in the literature. And specifically the word of involvement of the vitreous, because if the vitreous is not involved, usually it's not endophthalmitis. So we'll be talking about fungal section of endophthalmitis, and specifically about exogenous. The difference between endogenous and exogenous is actually based on the source of infection. So if you have a direct inoculation or extension from infectious keratitis, then you have exogenous endophthalmitis. Otherwise, if it's a hematogenous spread, then this is endogenous. Exogenous endophthalmitis is actually significantly more common, and 80% of fungal endophthalmitis is actually exogenous, at least in some studies, and mostly in centers where it is an ophthalmic tertiary center. So what is the rate of occurrence or prevalence of fungal endophthalmitis? In studies done in exogenous endophthalmitis, it was found to be not more than 16%, and the vast majority is bacterial. However, although it's rare, but when it occurs, it's really devastating and debilitating disease, and if it's not managed correctly, it can lead to loss of the eye and loss of sight. what are the possible etiologies and mechanisms of infection? So a study by Wyckoff found in 41 cases of culture-proven exogenous endophthalmitis that approaching half of the cases were actually related to fungal keratitis, 24% related to trauma, and 32 cases were related to intraocular surgery. Majority of isolated organisms were actually filamentous fungi. This predominance of filamentous fungi was actually confirmed by several studies, one of them by Silva. Traumatic endophthalmitis. You know that whenever we think of traumatic open globe injury, we think of fungus. And this is actually correct, but majority of traumatic endophthalmitis is actually bacterial. And it's really uncommon to have fungal endophthalmitis as a cause of traumatic endophthalmitis. What is the rate of occurrence of endophthalmitis in open globe injuries? There was a study done at the university, King Saud University, and it studied actually 213 cases, 8 of which were actually developed endophthalmitis, but there was no mention of fungal versus bacterial. We need to give intravitreal injections of antibiotics plus minus antifungals if we have high risk features presenting with the open globe injury. One of them is intraocular foreign body. If you have a lens rupture, or you have a contaminated object related trauma, or there is a dirty mechanism of injury, or there is a delay. So there was another study in tertiary eye center in China. They looked at almost 900 cases of traumatic endophthalmitis. Only 38% were culture positive, and out of these, only 17% were fungal endophthalmitis. So when we say it's rare occurrence, yes, actually it's rare. However, we need to put it in mind because traumatic endophthalmitis tend to be multimicrobial or polymicrobial, and they have the possibility of fungal is always there. As you can see here, we have majority of the cases are actually, majority of the organisms are actually filamentous. So post-cataract surgery endophthalmitis. This is actually hugely wide, hugely variable across the geographic locations. So if you go to the temperate locations of the globe, like in US or in Europe or Canada, you will find really exceedingly, it's an exceedingly rare occasion to have fungal endophthalmitis post-cataract. The large major studies reviewing result and outcome of cataract surgery will show you 100% prevalence of 100% proportion of endophthalmitis to be bacterial. If you go to a more tropical location like India, the proportions are a little different. So in fungal, in a study in India with 124 eyes developing endophthalmitis post-cataract, 21% out of the culture positive, 21% out of the total number of endophthalmitis were actually fungal, while 10% were confirmed bacterial. The rest were equivocal. So you can see in some centers in tropical countries, you will find fungal being even a higher in proportion than bacterial. Post-Keratoplasty Endophthalmitis. So the reported incidence is actually very low, lower than 1%. And in the recent reports, the prevalence or the incidence is declining. So it's not the same as it was before. Maybe this is related to some graft preserving techniques or standards being changed across the years. There was another study which looked at the culture positive endophthalmitis after BKB, and it was found to be 1/3 caused by fungal endophthalmitis, and majority were candida. You will hear occasionally that after doing BKB, you will be called by the laboratory telling you that the donor rim was positive for an organism. Sometimes it can be fungal. And you will be worried if this is your first time to face this situation. But actually, by studies and major studies, it was found that this is really causing very extremely low risk to develop any infection in the eye, even if the donor rim was showing positive culture. In a study in New York Eye and Ear Infirmary, 344 donor corneas with positive rim culture were actually studied, and it was found that 28 out of the 300 were positive for fungi, and all were candida. The rate of endophthalmitis was around 0.16%, so it's really extremely low risk for infection. Dr. Shabib did another study at KKISH, which is similar to the previous one, but it showed that there was, in all cases, there was no cases of post-operative fungal keratitis or endophthalmitis. And the most commonly isolated organism was candida. Now, the post-intravitreal injection endophthalmitis. We know that there are large, multi-centered studies for diabetic macular edema that study the efficacy of efficacy and safety of intravitreal injections, both anti-VEGF and other steroid agents. And there are almost no cases reported in the major studies, at least, that say that there are cases of fungal endophthalmitis. There are reports of bacterial, but fungal endophthalmitis is extremely rare. However, outbreaks may happen, and it can be a nightmare for the ophthalmologist and retina surgeon. A report by Scheiman was actually documenting 8 eyes of 8 patients who developed fungal endogenous endophthalmitis secondary to injections contaminated with Bipolaris hawaiianus. They investigated the outbreak, and they found that the reason was actually in the compounding pharmacy. The medication that they were using was actually Avastin or bevacizumab and triamcinolone, and they were mixing these agents in the pharmacy, and this actually caused the introduction of the organism. Keratitis associated endophthalmitis is another very difficult scenario, very difficult disease to treat and manage. The rate of development of endophthalmitis was actually 19%. They develop endophthalmitis at presentation or develop it later on. And these data are actually from here at KKISH by Justiniya. Aspergillus was found to be the most common organism, and it was found to be very virulent. And this was confirmed in all regions of the country, in majority of regions of the country, also by Khairallah in a study in 1992. So patients usually present with symptoms that actually correlate with the ocular signs. So if you have an anterior segment pathology or anterior segment presentation, you'll have certain scenario, certain complaint. If you have a posterior segment involvement, you will have different presentation. Symptoms can be decreased vision, photophobia, floaters, redness, and pain with variable degree of intensity. This is actually very important, the latent period for presentation. So one study by Chakrabarty in India found a mean latent period of clinical presentation to be different between post-operative fungal endophthalmitis and traumatic fungal endophthalmitis. So if you have a trauma, in mean, you need to expect your infection to start at 7 days. It can start in day 1, but however, this is the mean that they found in their study. Post-operatively, about 3 weeks is the mean time of presentation of fungal endophthalmitis. The clinical picture is widely variable. It can be very mild, indolent disease that will even be mistaken as a P. acne type of endophthalmitis. So you'll have this fluffy material at the capsule and the IOL, and you might have mild flare, mild KBs, with or without involvement of the vitreous. And this can actually be mistaken as B acne, and usually removing the capsule, removing the IOL during vitrectomy is diagnostic and as well as therapeutic. Another way of presentation, which is the other extreme, having a very fulminant necrotizing type of endophthalmitis, or at least infection if it's not involving the posterior. And as you can see here, we have a necrotizing infection that sometimes progress to phthisis and enucleation of the eye. So if the anterior segment was involved first, you will have keratitis. You will have, if you have a cataract surgery, you will have involvement of the corneal wound, anterior chamber inflammation, hypopyon, fibrin reaction. You might have a plaque at the lens capsule. But if you have like a post-vitrectomy type of endophthalmitis, intravitreal trauma that was a major, that was a posterior trauma, you'll have posterior segment pathology. Patients also might have eyelid edema, conjunctival injection, anterior chamber inflammation with absent red reflex and vitreous exudation. So is there a difference between candida and aspergillus? So actually by literature, the histopathology and the clinical picture is widely variable between the two. Candida can be less aggressive, especially if the patient is immunocompetent. Rowe et al. Looked at 25 eyes that were enucleated for fungal endophthalmitis. Aspergillus was more likely to invade the walls of the retina and the choroid. And this is opposite to what happens in candida. Candida usually stays in the vitreous and on the surface of the retina. Unless if it was like an endogenous cause, then it will be in the choroidal circulation. Aspergillus was more likely to cause thrombosis in the retinal vasculature with focal hemorrhage and exudation, and sometimes occasional retinal necrosis, which is atypical if happens in candida. Aspergillus is also more likely to cause thickening of the eyelid margin and grayish-white corneal stromal infiltrates. So what are the best ways to diagnose and to confirm the infection? Actually, the diagnosis of fungal endophthalmitis is actually mostly clinical. However, the testing, microbiological testing, can confirm your diagnosis, and sometimes it does not confirm the diagnosis. However, you need to rely on your clinical sense in this diagnosis, because you might treat the patient with antifungal, do complete surgery, and then the patient will be cured, but still the testing is still negative. So what's the difference between vitreous tab and vitrectomy samples? So the difference is huge, and it's actually very similar to what happens in bacterial. So in some studies, the sensitivity of vitrectomy samples were approaching 90%. And this is in comparison to the vitreous tab, which can be even lower than 50%. So definitely we can take a home message from this, that vitrectomy sampling is superior to vitreous tab, not only in bacterial but also in fungal endophthalmitis, and this difference is actually more emphasized in fungal endophthalmitis because the fungus can be sequestered in some area, and you have to remove the IOL, remove the capsule to be able to reach the fungus. Also, this effect was confirmed by another study by Sallam. They found that there was only a 25% positivity of cultures from vitreous tab. Another modality which we do not have here at KKH, which is the PCR utilization for diagnosis of fungal endophthalmitis. A study by Anand looked at 43 intraocular specimens of cases diagnosed already as fungal endophthalmitis. PCR testing was showing 74% positivity, while culture method were around 55. Another study was also confirming the same effect. So what's the role of B-scan in diagnosis of fungal endophthalmitis? B-scan can be helpful, at least in ruling out or ruling in the vitreal involvement. If you have very severe anterior segment pathology that you cannot visualize the retina, it can be very sensitive in detecting vitreal membrane formation, vitreal opacities. and the membranes usually have reduced mobility. Also, if you have like choroidal masses, as you can see here during the surgery, if you cannot visualize it, you can visualize it with a B-scan, and it can be more likely to occur in fungal cases. So in presentation, what is the difference between fungal and bacterial? Actually, it's a hugely different way of presentation. Bacterial is significantly more common. The association of bacteria is more likely to be post-operative. However, fungal can be more toward endogenous. I mean, if you go to endogenous endophthalmitis, majority of these are actually fungal cases. Bacterial is rapidly progressive over days. However, fungal can be in some cases indolent and develop over weeks. The lesions in bacteria endophthalmitis can be diffuse and can actually cause inflammation widespread across the eye. And if you see endophthalmitis and you do vitrectomy, you'll find that the whole vitreous is actually contaminated by infiltration. However, in fungal, you can have like clumped type of inflammation. So what are the parts of the management? We can have medical or surgical management. Medical management can be systemic or intravitreal, or let's say intraocular. So systemic antifungal management is actually mostly utilized in endogenous endophthalmitis. However, we still use it in exogenous endophthalmitis for several reasons. One important factor is that we have very good penetration of some antifungal agents if they were given systemically. Like if you give oral or intravenous voriconazole, you can achieve therapeutic levels after about 2 orally administered doses. So like after 1 day, 24 hour, you will have good concentration inside the eye from just giving two doses of voriconazole. Amphotericin actually was introduced in the late 1950s. It is known for very broad systemic efficacy. However, the penetration inside the eye is very low, and you might have risk of infusion-related toxicity and nephrotoxicity because it's only given IV. Because it has a large molecule, it cannot penetrate the non-fenestrated retinal capillaries. There are other formulations of amphotericin B, which is the liposomal amphotericin B. It can be reserved for cases of azole-resistant organisms, because sometimes you might have an organism resistant to voriconazole, and if you give this formulation, it can treat the systemic type of antifungal, and sometimes if it was given intravitreal, it can be helpful. Voriconazole can cause visual disturbance, so the patient can have temporary blurry vision, and you need to follow renal function and electrolytes in these patients. Regarding intravitreal injections, amphotericin B has been used, voriconazole has been used. Both of them have very good coverage over yeast and filaments. However, the risk of retinal toxicity is worrisome in amphotericin B, especially if there is a dilution error. So if you give over 25 microgram of dosage, especially if you will use air tamponade or gas tamponade or silicone oil, the drug will be overly concentrated and you can cause retinal toxicity and necrosis. However, this toxicity is less emphasized in voriconazole. Another difference is the half-life. So the half-life of amphotericin B is actually sometimes can reach up to 15 days, so 2 weeks of, especially if you have an eye that has a formed vitreous gel and you did not do vitrectomy, so it can stay in the eye for a very long time. However, voriconazole has very short half-life, which is about 2.5 hours. So is there any difference that happens in vitrectomized eyes? So we need to think about this whenever we are giving patients of fungal endophthalmitis intravitreal injection. What happens to the drug? Is it still in the eye? Do I need to repeat the injection or no? So you need to know that the main factor is actually vitreous liquefaction. So if the vitreous is liquefied either by age-related factors or by vitrectomy, then there is a change in the pharmacokinetics of the drug inside the eye. So the diffusion of the drug inside the eye will improve after vitrectomy because you will be cleaning the eye from vitreous. You will probably remove the capsule and the IOL, and the drug will be able to reach even more within the ocular structures. This is a positive, but there is a negative, which is the reduced half-life. So amphotericin can decrease from 15 days up to like 1.5 days if you do a vitrectomy. Another drug that has not been introduced to ophthalmology very strongly, which is the isavuconazole. It can be used systemic and intravitreal, and it has wide coverage against filamentous and yeasts. It has very high diffusion and very low level of resistance. It has been used in animal models, but not yet in human eyes. So what is the role of vitrectomy in eyes with fungal endophthalmitis? So the main role is actually diagnostic. We need to obtain a sufficient sample to be able to confirm the diagnosis and to isolate the organism. And we need also to visualize the posterior signs, because sometimes anteriorly you cannot see anything from the corneal condition or the anterior chamber fibrinous reaction hypobion. But if you clear all this, you can see the retina, you can appreciate the visual potential of the patient. Also, the benefit of vitrectomy is to remove the fungi from the vitreous, and this debulking mechanism is very helpful in reducing the load of fungi from the eye and also delivering the antibiotic. You can also clear the media and improve the vision of these patients, and this is not if you are planning to remove the IOL, because sometimes you might have a patient with indolent form of fungal endophthalmitis. His vision is 20/50, 20/60. You remove the IOL and then he's back to count finger or so. Also, you need to decrease the vitreoretinal traction. So it was found by studies that if you do vitrectomy, you can reduce the vitreoretinal traction in patients with fungal endophthalmitis. So about the reported outcome of vitrectomy in these patients, there are no randomized clinical trials in this subject, unfortunately. Why? Because we have very rare situation, and there are different ways of management among surgeons. So you'll find people operating at different times. You'll find people operating different ways. Some of them will do a stepwise approach. Some of them will do aggressive, on-spot, very early intervention. So for that reason, it's very difficult to perform trials on this subject. What about removal of implants? So this is always controversial. We will find retina surgeons or even other surgeons frequently discussing is it helpful to remove the IOL or any other implant in this context or no? And it was found that there are actually contradicting evidence in the literature, but there are many cases and many case series of eradicated infection after removal of the intraocular lens. Sometimes fungal endophthalmitis can be mistaken as B. acne, and in these cases, when the IOL is removed and the capsule is removed and the infection is dealt with as B. acne infection, this can be curative of the disease. What's the point of removing the IOL? Actually, there might be a sequestration of the fungus inside the intraocular bag complex, and this will result in poor diffusion of the antibiotics inside this area. So if you remove it, you can diagnose the infection by doing proper histopathological workup, and then you will be able to cure the problem. Similar to the outbreak that we have in Jeddah, there was another outbreak of 20 cases of Fusarium endophthalmitis after cataract surgery. 19 patients underwent vitrectomy and 14 only had IOL removal at the time of initial vitrectomy. Most of these patients who had IOL removal had cured disease. The remaining needed another vitrectomy and another surgery to remove the IOL, and most of them, after removal of the IOL, developed actually, they were cured from the fungal infection. Another study of 5 patients, actually this was a case series, and it shows you here the significant improvement and the control of infection that happens if you do early and aggressive surgery. 3 patients achieved the final visual acuity of 20/20. 1 patient achieved bis-corrected of 20/50, and 1 remained hand motions, which was the baseline vision. And the authors of this case series were actually giving like a plan or like an instruction how to achieve this good visual outcome. And according to their point of view, they were saying that early and complete vitrectomy to establish the diagnosis and to remove the fungal elements from the intraocular structures is actually very important. If you have like a recurrence of the disease, you need to do a prompt surgery, to do even more aggressive surgery with the injection of antifungal agents. You need to not to hesitate to inject antifungals anytime during the course of the treatment. And if possible, you can cessate or stop topical and systemic steroid if that is possible, if there are no contraindications. What is the role of endoscopy? So, in one case report by Comer, there were 3 cases reported the use of endoscopy to visualize the area between the iris and the ciliary body, and you can see that sometimes sequestration of fungal elements can be found within the zonules or within an abscess at the zonular area or anterior vitreous space that you cannot visualize if you do not use the endoscopy. So it can be very helpful and handy, especially in this scenario. So all 3 cases of fusarium endophthalmitis were cured after doing this step. What are the possible complications of fungal endophthalmitis? We know that these patients can go downhill, either to phthisis. Sometimes they might require enucleation. In a study by Wyckoff, 41 eyes, 10 patients of them, which is about one quarter, underwent enucleation at the end. William reported the occurrence of RRD, retinal detachment, during or following vitrectomy of about 8 cases of 19. This may not be generalized to everybody. However, you need to know that when you go to vitrectomy for fungal endophthalmitis, you can face RRD intraoperatively or it can develop later on. And if you do vitrectomy, it can relieve the vitreoretinal traction and possibly prevent retinal detachment in the future. Salam et al. Also reported that early vitrectomy may be protective against RD. Additional possible complications can be the occurrence of epiretinal membrane and macular hole, and there has been scattered reports of successful treatment of these after fungal endophthalmitis. So to conclude, I'd like to mention that the clinical picture of fungal endophthalmitis is widely variable and the diagnosis is frequently missed. The diagnosis is mostly clinical, and microbiological testing may or may not support the diagnosis. Early and aggressive vitrectomy with removal of implants is advocated by many authors. However, level 1 evidence is still lacking. Thank you very much.
Thank you very much for this big and then very thorough review of the topic here. So now the floor is open for any questions.
Assalamu alaikum.
Alaikum salam.
Allah. Very informative lecture. Thank you very much, especially at this time. I have a question. Did you come across anything talking regarding the role of surgical iridectomy and the surgical management of fungal endophthalmitis?
Well, actually, there was no reports of removing the whole iris in these cases, because mostly when the fungus is invasive to the iris, it's mostly also invasive to the choroid, invasive to the ciliary body. So personally, I don't find any point of removing the whole iris. There are reports of removing nodules that grow over like a sector of the iris. You can cut that sector and suture the iris. This can be curative in some case reports. But there was no study that looked at this in a comparative way, whether if you do it will be curative or not. there was actually no good studies in that direction. But actually, this is a scenario that we face frequently. You will find very aggressive, very invasive type of fungal infection, and you find that the iris is very severely invaded and white. You will get a question in your mind: should I remove the iris or not? Personally, it's a very difficult decision. But what I would do myself, I would not remove it. I would just clean it as possible. And if there is like a sector that is involved by a clump or an infiltration, there may be sectoral iridectomy can be performed.
Thank you very much.
Thank you. Thank you.
That rarely be touched.
Thank you.
As you know that we had gush of cases that refer to our hospitals from Jeddah Eye Hospital, and most of the cases that came to us were seems that either managed, the management was delayed or not managed in the way that with vitrectomy and tried to eradicate as much as possible, and even though the organism wasn't that thorough. So in such situation, and you've been, I think, comfort in such cases.
Yes.
You can give highlights for that, so that this is the first.
Okay, so thank you for the interesting entrance into the problem, Dr. Hassan. We actually would like to ignite a discussion about the cases that we had. All of us in the retina division and in other divisions have faced similar scenarios from the outbreak. Myself, I received around 4 cases. Only one of them was actually confirmed fungal. For all of them, I removed the IOL and I did complete vitrectomy. And the last one of them was actually seen 3 weeks ago with the stoppage of steroid medication. None of them had recurrence from one surgery. But I do very, very aggressive surgery. Some of them presented 5 months after the outbreak. Some of them presented 3 months after the outbreak. But I'm not the one with the maximum number of cases presenting to me. Maybe other colleagues can help if someone has any.
We're trying to collect these cases and looking for outcome for all the hospitals who are in the analyzing stage now.
Yeah.
It's not, but some of them being, getting recurrent courses, after even that an aggressive and the bulk hole of the vitreous, removing the eye walls, but still, having, recurrency.
Yeah.
That's,
so I think if these cases were managed with the classic tab and inject initially, and then they were watched for a while, and then another minimal surgery like core vitrectomy and injection of antibiotics was done, I think this way of handling the cases will lengthen the morbidity of the eye. This is what I have understood. I don't rely on solid evidence, but this is what I have seen from the experience that I got from talking to my colleagues. Maybe someone can give us their input
Thank you, Abdullah. Very informative lecture. So I agree with the fact that you should go with IOL explantation in these cases. The case that we had multiple recurrences despite treatment. The patient quietens to the degree that maybe I should not do anything. Recovers 20/20 vision, then he comes in the next visit with recurrent, full-blown picture of endophthalmitis. So IOL explantation is needed, and there was a recent case series from India and the American Journal of Ophthalmology case reports, and they reported an outbreak of fungal endophthalmitis, and they strongly recommended IOL explantation in these cases as well. I would like to point out something that you mentioned about stopping steroids in these patients. I know this is what we do in general. We try to avoid steroids in patients with suspected fungal endophthalmitis or even keratitis. But in endophthalmitis, there have been studies on animals that if you give the right antifungal treatment, then steroids can be given intravitreally. But in general, we try to avoid it, but keep that study in mind. It was published in Retina, but I don't remember which year.
What is the possible timing that if you will give a steroid, would you give it intraoperatively or give it days later?
So, and if it was me, I will cover with antifungal first, then I will introduce steroids slowly.
Okay. So you'll give topical steroid, not intravitreal steroid.
If you are going to give intravitreal, you give something that is short acting, like dexamethasone, not triamcinolone.
Sure.
I have one more comment. During COVID, that in the late crisis, they have discovered a lot of cases of endogenous endophthalmitis, especially for these people who admit in the ICU. And lately, from thought that there is a outbreak of mycor, fungal infection systemically. I don't know. Did you get any cases of mycors endophthalmitis?
Of what?
Mycor endophthalmitis.
Mucor mycosis. Well, actually, I did not look into this. It's usually more of a concern of oculo because they will have yeah. So I try to limit to the more organism that will develop endophthalmitis, and as we said, it's mostly filamentous. So mucor is very rarely cause endophthalmitis, unless if it's like an extension from banophthalmitis or.
Yeah, I think there should be a clear distinction between endogenous endophthalmitis and the exogenous fungal endophthalmitis. So, in endogenous, I think the approach should be a little bit different. You don't have to be very aggressive surgically, but be aggressive in terms of systemic treatment.
Yes.
And they may need 6 weeks of systemic antifungal therapy, in addition to the intravitreal injections. Even if you do vitrectomy, the lesions are in the choroid and in the subretinal space. You may not be able to debulk them. They are intraretinal. So systemic treatment is the mainstay, in addition to intravitreal injections and endogenous fungal endophthalmitis.
I had one case of choroidal abscess, fungal. It was too big that to get even though clear it up. Yeah. We clear the vitreous, but the abscess itself, it's difficult to reach it.
يعطيك العافية دكتور بهلال. Well done as usual. During the outbreak, I had privilege to treat one gentleman. It was a little bit weird because that patient, it wasn't only the endophthalmitis, it was also the scleritis, and it was not related to the port. No, it was related to the near adjacent, limbal, I would say, like in limbal infiltrate. I have two questions. First of all, of course, you mentioned already that systemic antifungal is a must. So for that patient, it was not placed on, but he improved when I placed him actually on the systemic. What in case if the patients don't improve, if they have an endophthalmitis with scleritis? Okay, this is the worst scenario that anybody faced with. In your situation, let's disregard there is a keratitis. Would you go for an injection, a frequent injection topically with any antibiotic, let's say fluoroquinolones, amphotericins, trying just to surround the area, to try to salvage it, or would you go for a cryo? Because for us, when we do therapeutics, we intend to inject actually the sclera, especially if we are not 100% sure that we amputate all the limbus, and all the necrotic area. So we tend to do that one. What about if you don't have corneal rheumatoid, you're only just facing this issue with endophthalmitis? What is the recommendations?
Well, actually, I didn't pass by anything that relates to scleritis per se, but I've come across several several endophthalmitis with scleritis that were treated successfully with vitrectomy, intravitreal antibiotics, antifungals, and systemic antifungals. Personally, what I would do is actually if there is an intraocular fungal infection, I would do maximum aggressive surgery from the beginning, and I will extrapolate from what you do from like corneal intrastromal injections. I would do the same for the sclera. If there is like a Ahmed valve or something, I would definitely remove it. And I think, let's hope for the cure. I mean, the cure from doing this only. I don't know if you actually. The answer, the question is directed to you, Dr. Samar. Maybe you need to do a complete patch graft at the area, like excision of the whole sclera, and then like putting a new non-infected sclera. But I think you have your own indications for doing this.
Definitely, but there are some areas that you cannot do a patch for it, you know, and
Yeah.
it depends on the extent. Otherwise, you'll expose the whole uveal tissue. But yeah, I think probably like doing these injections with the systemic would be. But this is one of the most important things because people always tend to concentrate in inside the
Intraocular,
eye,
yes.
intraocular, and they forget that under this there sometimes be some scleritis involved
Yes,
as
definitely,
well,
yes.
especially like what I've seen in that patient. You know,
Definitely,
and
yes.
people miss it. Yeah. Okay. Thank you.
Thank you, Dr. Samar.
Dora, I have a couple of questions. First of all, a small comment. We were lucky to have the PCR back in Barcelona, and it's really helpful because most of the scenario you face right now is the patient already treated. So you try to get the microbiology for that, you're going to fail. The nice thing of the PCR, you get the vitrectomy from the cassette of the vitrectomy here, and then you can get a diagnosis of the fungal species we treated the patient without even any growth. So the thing is, it's quite useful technology. It's expensive, but in this case, it's very necessary. It's really good tool. And I will shift the attention to other place. So you mentioned that there is a lot of retinal detachment in this series of cases of vitrectomy. So do you think that for the sake of discussion, something else has to be done in these patients out from the vitrectomy setup, for instance, instead of doing laser. Or the tamponade and everything? What is your opinion about that?
Actually, there are no big studies comparing whether if you do prophylactic laser or if you do like an adjunctive buccal as a primary scenario, whether you will protect against retinal detachment. They only report retinal detachment, and when it happens, they manage like any other retinal detachment. Personally, if I find like a retinal break or there was an area that is suspicious for vitreoretinal traction, I will clean around the vitreous, and then I will do laser to that area. And I hope that will be enough. But still, the risk is there. I might put tamponade. Some people will use the tamponade as a bacteriostatic type of effect. This is not actually supported very well for fungal infections. So in bacterial endophthalmitis, you might put silicone oil thinking that this can be bacteriostatic. But this does not go very well with fungal. And fungus can continue growing even if there is silicone oil. The important point is that you need to make sure that the dilution is correct. Because if you give the concentrated solution of antifungal agent and there is a silicone oil, you might cause toxicity to the retina, especially in amphotericin.
Thank you,
Thank you, Dr.
for
Ibrahim.
choosing this important subject and excellent presentation. It's not a question or information about the other implants other than the IOL,
Yes.
especially the glaucoma implants. There are a lot of MIGs now in addition to the tubes. What do you think about this?
Well, actually, if you apply the same principles of removing the IOL, because the IOL can be a reservoir for fungi, it's a foreign body. Any foreign body, like if you have a knee joint that is artificial and if it was implanted infected, they will remove it definitely. Because foreign bodies can be like a reservoir and sequestered, and the fungus can be sequestered there. So I would think the same thing in eye stent. I would think the same thing in Ahmed valve or any other implants. But there is something specific about the IOL. The IOL usually, when the infection happens post-cataract surgery, and you do viscoelastic injection, sometimes the viscoelastic, if it was a methyl cellulose and it was not prepared well, it can be contaminated, and this can be sequestered in the bag, and the IOL will be preventing this organism from prevent the antibiotic from reaching to that organism. This is less in eye stents. Eye stents cannot sequester like an IOL bag complex can sequester things. So if it's going to be risky to remove an eye stent and it's going to cause hyphema and cause problems, then I would not think of removing it. Yeah, but it's really a controversial issue. Sometimes you will operate and you don't know that there is an eye stent.
Yeah, probably as you said, the tube is more important because there was a case where the eye was cleaned of this inflammatory material, and then things came, the other way from the tube itself.
Yeah.
Thank you.
So, Dr. Ibrahim, you recommend removing tube and
Yes.
these.
At
So, any
lea-
fungal you recommend?
Yes, at least pulling it out of the eye and putting it out.
Yeah.
If not removing the whole implant, especially
Okay.
if you see.
What happens if there is a blip? Do you advise the excision of the blip in these cases?
I don't think so, because in that case there is no foreign body and it will
Yeah.
be reached by the antifungal.
Okay, so it's very informative. Okay, Abdulaziz.
Thank you, Dr. Abdullah, for the informative lecture. We came across one case with fungal endophthalmitis from the outbreak with good vision, 20/50 vision, with the single colony in the AC, with recurrent infection once they taper the steroids. So in such case, would you go for aggressive radical surgery or removing the IOL, aggressive vitrectomy, or would you like to keep the patient under topical medication, or, for example, treat and extend the strategy?
Well, actually, as I said earlier, I had a similar case. The vision, he was operated 5 months ago, cataract surgery. It was uneventful. The vision was 20/60 when he presented, but he had vitritis. He has a +2 vitritis. So, in this patient, I told him, you will have a drop of vision. You will not see after the surgery, but I have to remove the IOL. I cannot guarantee that the fungus is not sequestered inside the IOL bag complex. And he agreed, and we removed it, and now, alhamdulillah, he's cured. I'm booking him next visit for sclerofixated IOL. Hopefully that he will come also, remitting.
Thank you. Second question, does silicone oil has any role? For example, if you do a vitrectomy and there are no breaks, would you
Yeah,
consider
we
putting
just
silicone?
spoke about this. So we said that the bacteriostatic effect of silicone oil is not the same in fungal endophthalmitis. So there are very few studies that talk about this, but it has been reported to recur even if there is silicone oil inside the eye. Okay, so thank you very much, everybody. By this we conclude the lecture. I hope everybody got something out of this lecture. Thank you very much.